Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to this episode of the Doc Podcast. Today, my guest is Dr. Dave McCarty. Dr. McCarty is board certified in both internal and sleep medicine and is a distinguished clinician, educator, and author with a passion for demystifying the complex landscape of sleep medicine. Dr. McCarty has dedicated his career to creating innovative, patient-centered solutions that bridge the gap between providers and those they serve. He is the visionary behind the Empowered Sleep Apnea Project, a groundbreaking educational initiative designed to simplify the complexities of sleep medicine. This cross-platform resource empowers both patients and providers with a shared language, fostering better communication and improving outcomes. As Chief Medical Officer of Rebis, his goal is to create a truly integrated, multidisciplinary approach to sleep medicine, leveraging cutting-edge research, data-driven strategies, and patient-first innovation. With his unique blend of medical expertise, creative storytelling, and educational leadership, Dr. McCarty is not only advancing sleep medicine, he is truly reimagining it. He is also an accomplished cartoonist and one of the smartest and most creative people you will ever speak with. And today, we are going to dive deep into all things sleep apnea to see how Dave is working to revolutionize the ecosystem of sleep medicine. So without further ado, let's get on to today's episode with Dr. Dave McCarty. Enjoy the show, everybody. So welcome to the Doc Podcast, Dave.
I am delighted to be here, Mike. Thank you for inviting me.
Well, thank you so much for coming on. It's an honor and pleasure to have you on. I've really enjoyed getting to know you since we met about 8 months ago or so now, 7-8 months ago, and been speaking a bunch since then. And I was honored to be asked to speak to your group at Rebis last week. And that was a lot of fun talking to them. And we will talk during the show about some of the amazing things you are doing. But just before we do, as you know from listening to the show, I love hearing about people's journeys and how they got to be where they are today. So how did you get to be the Dr. Dave McCarty that you are today?
It's a long story, so I'll try to make it short. I'm a recovering primary care doc. Let's start there, okay? Mm-hmm. I'm an internist, and I'm a primary care doc by training and kind of by nature. You know, when I started this journey, I just wanted to be someone's doctor. So I used to tell the joke, I wanted to be Marcus Welby, but nobody knows who he is anymore. So I wanted to be like Hawkeye Pierce. I wanted to be like the people in the TV who helped people and solved problems, So off I go to medical school and I become a primary care internist. And it was when I'm doing my trade as a primary care doc, taking care of people with problems, that I started going down the rabbit hole of refractory hypertension. Refractory hypertension has a definition. That's when you're on 3 different medications for blood pressure, including a diuretic at good doses, and your blood pressure is still not under control, right? That's the definition of refractory hypertension. And right when I graduated from residency, it was right around the turn of the century, believe it or not. It was the year 2000. The Joint National Commission for Blood Pressure Management had come out with new recommendations. And they, what we had been taught in medical school, that if you have big, bad, high blood pressure, you're supposed to look for adrenal gland tumors, like a pheochromocytoma, or something like renal artery stenosis, where the renal arteries are kinked off, and that's why you have bad high blood pressure. And so we did that, and we did the due diligence. We did the tests every time somebody had bad blood pressure, and he never found anything because those problems are pretty rare. So it was right around the time that I was graduating that the new recommendations came out that said, look, if you've got refractory hypertension, you've got to look for this thing called sleep apnea. I'm like, what? Sleep apnea? I learned a little bit about that. I'm looking back at my medical school days. We had one lecture on sleep. We had probably a couple of hours about sleep-related subjects in residency. So I started to send people to get sleep studies locally. And this was in Shreveport, Louisiana. At the time, I was in the military, right? I was a captain in the Air Force, and I was serving our nation's people. I was taking care of mostly retirees and their spouses, because I was the only internist at Barksdale. So I inherited all the really complex medical disorders, So I'm busy sending sleep studies right and left. And there was one doc in town. He was a really nice guy. He was recently converted to the sleep apnea narrative. He's a neurologist in town. And so he was very, very passionate about sleep apnea, you know. And so when my patients wouldn't use their CPAP machines, he was a very heavily accented Indian gentleman. And so he would get very passionate. He'd say, "You have to use your CPAP machine." And he would yell at them like this. And my patients would be frightened and they wouldn't want to go back. And so here I'm holding the bags. Literally, I'm having to manage these people now because they didn't want to go back and see the one gentleman in town that took TRICARE. And so I bought a textbook. I literally bought the textbook. It was at that point, it was in the 3rd edition. It was the Krieger's Principles and Practice of Sleep Medicine. Because I'm like, if I'm going to do this, I better read the book. And, you know, internists do this. Internists do cognitive work. You know what I mean? So like, surgeons learn how to do a technique. It's like, oh, there's a new test. Well, I better learn how to understand that. So by that time, I'd already learned how to do exercise tolerance tests, a treadmill test. I learned how to read PFTs. I learned how to read Holter monitors. You know, so I'm like, what's the big deal? It's another data set. So I figured I better learn to understand what I'm doing. So at this point in the journey, this was potentially a billable procedure that I was missing out on. That was how I thought about it. So I decided I'd go get some training. So off I go to a place called the Atlanta School of Sleep Medicine. This would have been about, 2004, 2003. And they purported to be able to teach you in 1 week's time to be able to read and then therefore successfully bill for reading sleep studies. So I'm like, cool, this is going to be awesome. You know, I've got a new thing that I'm going to be able to do. So I go off to Atlanta, I tour the Coca-Cola building, and I go to this CME class, and I'll just cut to the chase. At the end of that, I was blisteringly scared because I'll tell you, the polysomnogram is not an EKG. Okay, it's not a 12-lead EKG. There is very little order to this. It's just so much data. I'll put it that way. There is a way of doing it, and there's a way of acquiring that data and a way of displaying that data. But I'll tell you, it is nuanced and it is complex and it is deep. And so by the time I emerged from that CME course, I realized, oh my God, here we go. And so shortly thereafter, I literally cold called. I made an appointment and cold called a man named Andy Chesson. Dr. Andy Chesson. And it just so happens he was right there at LSU Shreveport. He had a sleep medicine program that was nascent. It was small. It was an apprenticeship style fellowship because that was the way things were back then. But I called him up and I said, hey, can you teach me how to do this? And he said, he kind of chuckled because like I didn't even know what I was getting into. He said, well, you know, yes, but, and then he went on to say, this is actually a thing that up until now, this had been a certification process that you train under the American Board of Sleep Disorders. And it was the American Board of, I think it was the American Board of Sleep Disorders. I think that's right. And you got a certificate that you were allowed to read sleep studies. It was a rigorous testing situation, and you had to, it was like 2 days of oral exams. Like it was a big deal. And he says, so we're switching this, and this is actually going to be a board certification process. And multiple specialties are sitting at the table. I'm involved because actually Andy happened to be a past president of the AASM. So he was a big shot up at the academy and was helping to design how this was going to look. Because if you think about it, there are lots of players in the game of sleep medicine back then. It was pulmonology, so internal medicine. It was neurology. It was psychiatry. It was pediatrics, ENT, anesthesia. All of those were players. And depending on where you were academically, the sleep lab was in maybe in the psychiatry department, and maybe in the internal medicine department. It was in the neurology department. So all these different people with a seat at the table are going to want to have some sort of say as to how this fellowship looks and behaves. So all of this is to say that 2007 at that point was set as the very first board exam was going to happen then. So I had this conversation with Andy at about 2004, and he saw that goalpost coming because he was planning for it. So what did I do? I shut my primary care practice down to 3 days a week. So I was only working in my primary care clinic 3 days a week, and on the weekends rounding in the hospital and stuff. So you're working all the time. But 2 days a week, I would go and follow Andy Chesson around. And he would read sleep studies in the big phone books and the paper charts, the way we used to. And then we were just switching over to the Alice system electronically. So I got to see the transition to the electronic reading of sleep studies and what advantages that gave us. And I got to be in sleep clinic as a trainee. So it was kind of humbling. I'm 4 years into my career as a fully functioning primary care doc, and I became a fellow again. So I started signing out to the sleep medicine attendings and presenting cases, and I learned as I went. And at the end of all of that, in 2007, I sat for the very first boards and passed them, thankfully. And when I did that, Andy asked me to join the faculty. So I did that, and I started as the associate program director. And my job was basically to help him turn his apprenticeship style fellowship program into an American Board of Medical Specialties accredited fellowship program, which basically means you write everything down and you keep logs of everything and you organize it and you show what you're doing, that it's in compliance with all the curriculum requirements. So that's kind of what I did. I became a professional secretary, and I sort of wrote everything down, helped create a program out of sort of magicianship from before. And when Andy retired, I became the program director. Wow. So that takes us back to about 2012, 2013. Okay. And so it was after that I decided academics was a little bit too confining, the straight and narrow, the rules, and do you have this or not, and how do you get into the clinic? All of that was, it felt kind of confining after a while. I started to see that we had a hard time accessing non-standard. So for example, one of the things I noticed about our program early on was that even though the textbook had chapters about oral appliance therapy, there was no practical access point for this. So in terms of teaching my fellows, there was nobody who knew how to do it. We just didn't have access to that. So it was a very siloed sort of educational system for me. It just so happens that a good friend of mine in Shreveport was a man named Tom Colquitt. And Tom Colquitt happened to be on an airway-focused journey himself, and he was a dentist. So Tom and I happened to be friends outside the clinical realm. He and I are both, we lost Tom last December. So Tom, if you hear me, I love you. But Tom was a musician, and so am I. And so he and I sort of were magnetized together for that reason. And we had a relationship outside of medicine. And so I cold called Tom and I said, hey, I know you're doing this dentistry thing for sleep. I don't know much about it. Do you mind if I take my fellows over to your house for a field trip? And so once a year, I would take my fellows over to Tom's office, and he would show us all the things that he was doing, and he would give us his lens of airway-focused dentistry. And it kind of helped to open up the receptiveness of the fellowship program to something that's less standard at that time. Now, mandibular advancement type oral appliance therapy is sort of standard of care in medical worlds. And the more expansive airway-focused dentistry that focuses on developmental aspects of the airway and expansive orthodontic options, that's a little more maverick. And the AASM and the AADSM haven't really sort of paid attention to that yet. But it's because of my relationship with Tom that he opened up the doorway for me to kind of understand that this is going on as a field engineered option. And that kind of brings me to where we are now. So I told you I could talk too much.
Not at all. That was awesome. And a couple of points I want to make on that and this is such a common theme, and I say this all the time, but it's true, that people who achieve great things and continue to find success are willing to take calculated risks along the way. They don't play it safe and just lay up. They're willing to go for the green. They're willing to take that extra chance, and they're willing to accept the consequences therein, right? Your ball may end up in the water. It may happen, and it probably does a time or two. And you have to realize that you're going to have some failures. But the fact that, correct me if I'm wrong, you cold called both Andy and Tom, right? At different points. So, I mean, I want people to hear that, because I know for myself, as I went from my private practice arena into this more educational arena, I had to do some cold calling to people and just say, hey, look, our emails, cold email, or reach out and say, I'd love to talk to you. I'd love to speak with you. And it's amazing how receptive people are to that. A lot of times they're almost relieved that there are other people out there who want to hear some of these things. So I would just say for everyone out there listening, I encourage you, if you're thinking of something or passionate about something, don't hesitate to reach out to that person or those people that may be able to help you learn more about something. Because in the end, look what it did for you. It brought you to a new level, not only the personal relationships you developed with these individuals, but professionally, how you grew. And then all the people you have helped since and are continuing to help is just amazing. So I love that. I love hearing people's stories because, again, people know you for who you are today, and you're a big name in the field, and people know you have an amazing book, which we'll talk about, and you're doing a lot of great things. I feel very important for people to realize, especially the younger docs who listen to the show of any specialty, of dentistry, medicine, whatever it might be, you got to start somewhere. And you know what? You got to pay some dues. You're going to have to knock on some doors. You're going to have some really hard hours pushing forth to get to that point. So I appreciate you sharing all that.
Well, this is no secret. I tell everybody I was an English major in college, and it explains kind of my strangeness sometimes. And amongst docs, that's a little unusual. Most of us were biochemists or something like that. And so I love words and I love writers. And one of my favorite writers is Ralph Waldo Emerson. He's one of our nation's luminaries. And he said, nothing great was ever achieved without enthusiasm. And so the word enthusiasm has been high and sort of present in this journey, because I think enthusiasm, it literally means like imbued with the breath of life, enthused. So it's your clue from the universe about where you should go. The thing you feel enthusiastic about, that's your secret, man. So if you can find it, please follow it. That's what that trip to Atlanta brought me. That's what the fear that generated. That was an enthusiasm of, oh my God, it was the fear of being on a roller coaster. That was how it felt. And when I decided to follow that instead of shrink from it and go see Andy, it was literally when I walked in his office, I had that, here we go sensation. Right. That when you just crest the top of the roller coaster and you're about to go. Yeah. That's what it feels like to follow your dreams. And so thank you for noticing that. It really was transformational to do those things. Yeah. And you wouldn't be where you are today if you didn't. Yeah. Literally. Literally. You would not. Literally. It set you on a path to change a lot of lives and really help a lot of people. One of the things I think is interesting is you have a little bit different, or say unique approach to how you talk about sleep apnea. And that's evident in listening to your podcast, reading your book, or hearing you speak. I really like how you, and it's interesting because it kind of ties into, in our world, in the dental world, kind of the Pankey Institute mindset. I had Paul Henney on my show who talks about the Bob Barkley Study Club. Yeah, and Paul was one of my first sort of contacts that Tom, actually, it was all Tom. Tom's like, you got to meet my friend Paul. and that was where I learned about the Pankey Institute. Yeah. And I'll say this out loud because I know your community is mostly dental. I think it's awesome. And I think it's compelling that I have learned so much about being a healer, and I'll say the word, a doctor, right? I've learned so much about that art from the dental community through this sort of Pankey. It's all about person-centered care, right? Person-centered care. And as I reflected on this, why did this happen? Why did the dentists have to show us how to do this? And the answer became, I think, money is a barrier. The way we practice medicine now is very tightly regulated to be diagnosis and treatment-driven compensation. I can't see you in clinic for this diagnosis because it's for mental health. That's actually true. Yeah. Because I can't bill for it. So you end up billing for fatigue instead of depression. You know what I mean? Right. Yeah. And so you figure out these workarounds, but it changes the way you think, It does. And when I talked with Tom about this, he said, Dave, the more I think about it, the more I realize I was able to do it this way because I didn't have any debt. And I bill fee for service. Right? Yeah. It's very freeing. And so it allows you to think about things with the patient first rather than, how am I going to bill for this and how am I going to get this through? And, it really does put your brain in kind of a box. It's so true. So, I actually feel
an interesting twist of irony here, that's part of what's holding up my orthodontic colleagues from going on this journey and exploring sleep and airway more, because it doesn't fit within the box of billing of comprehensive orthodontic treatment or code D8080 or whatever. You know what I mean?
Yep.
It doesn't fit within that code. And I hear all the time from people that say to me, yeah, but Mike, if we treat them early, we use up all their benefit and then they don't have any money to pay for treatment later. I mean, I hear it all the time. And it's exactly what you are saying. It's the concept of letting the reimbursement drive the practice. You are.
Yeah. It's literally what we're seeing out there today. Yeah. So you started the question with I have a unique approach. So my unique approach is I want to take this complex array of physiology that's kind of hard to navigate, and when I use the word complex, it's a loaded word for me because I've been on a deep dive of how is complexity managed over the last 4 years. And so let's just start with sleep apnea. I say the word sleep apnea. Somebody walks in the door, they have sleep apnea. What is that? And the answer is, well, it's complex. A given person with that label is going to have some degree of obstructive sleep apnea, some degree of central sleep apnea, because it exists in all of us, right? Especially here in the mountains, right? The higher you go, the more central sleep apnea you got. But these two entities are always mixed together like a vanilla chocolate swirl, okay? They're always together. Sometimes, the chocolate is only negligible. That'd be like something that's mostly an obstructive problem. But sometimes the chocolate is really front and center. And the thing is, it's hard to tell the difference between the two because hypopneas generally are just designated as a generic phenomenon. Apneas, you can tell whether it's obstructive or central. So you can say it's an obstructive apnea or central apnea, right? But a hypopnea, an underbreathing event, is generally just designated a hypopnea. So if it's a central hypopnea, that's caused maybe because you've got periodic limb movements of sleep causing arousals from sleep and your breathing is unstable because of that, that can give you central hypopneas, right? To the point where it could give you an AHI that's literally, quote, severe. But it's not the same thing anymore as Pickwickian syndrome with severe obstructive sleep apnea and 30 obstructive apneas per hour, different, but the AHI would be the same. So now we've got a conundrum because the AHI by itself doesn't carry communicable information anymore. It carries a code that you need to unpack. So if you don't know what you're dealing with until hindsight, we'll put a CPAP machine on it and see if it gets better, right? If it gets better, then it was probably obstructive. Okay, great. But if you don't know how it turns out until hindsight, that's one of the definitions of we're in a complex environment now. This is not a linear relationship to like start to finish, right? So with complexity, there is a way of unpacking this. And it's not about, just label it and go forward. It's about, get into it, poke it with a stick, figure it out, and let it emerge in real time. And that's something that requires the patient's involvement to do it. Otherwise, they're going to feel jerked around, So my approach is I want to take all of that complexity and I want to democratize it. I want to take it out of the hands of the gods and the doctors who understand it and say, you have sleep apnea. Go forward and follow this algorithm from now on. And I want to take this complexity and I want to put it on the table in front of the patient so that the provider and the patient can regard it and actually deal with it, together as a team, as a collaborative team. That's the way complexity should be investigated. And that's what the Empowered Sleep Apnea Project is all about. The subtitle for it is a handbook for patients and the people who care about them, not just the people who care for them. Right. The people who care about them. So that would be you, Mike. That would be the patient's spouse. That would be maybe the people working the front desk. They care about the patient. So they should understand how this complexity works too, you see. And that's my secret delusion is that if we all kind of get it and we can all speak the same language, then all of a sudden the silos disappear. Yeah.
I do. And talk a little bit more. You touched on Pickwickian and the label of that from Dickens. Sure. Talk a little bit more about the evolution of sleep apnea or sleep disease, if you could, because you have a tremendous perspective on it. I feel like, especially the younger docs in medical dental, they're hardly learning about it in today's day and age. Like, where do you even start to wrap your mind around this? Hey, everybody. We all know that we don't learn much about interceptive orthodontic treatment, especially as it pertains to airway. That's why I created a comprehensive CE course that you can access through the doc website. This 26-hour course will transform how you think about and approach interceptive treatment and teach you how to implement airway-focused orthodontic treatment into your practice. Just go to theorthocoach.com and click on the courses dropdown. I'll also put a link to it in the show notes for today's episode. If you're looking for ways to improve the health and truly change the lives of your young patients, then this course is for you. And now back to today's episode.
Yeah. So this takes us all the way back to the early 1900s, okay? Sir William Osler, one of my heroes, the first chair of medicine at Hopkins. So one of the first luminaries of modern medical thought in America. He wrote in his textbook, it was a single author textbook that he wrote, he described how it's interesting how young people who are heavy, who are fat people, tend to fall asleep a lot, like the young man in Pickwick. Because, of course, Pickwick Papers was Dickens' first novel. Okay, it was published back in the 1830s, I think, and it featured sort of comic relief. There was a character that was only called Joe, and everybody later called him just Fat Joe because he was an obese young man who literally makes his appearance in the novel by falling asleep on his feet. He's knocking on a door and he snores himself to sleep while knocking on the door. So, and this happens frequently. Like every time you turn around, Joe's falling asleep. And so Osler made a note that Dickens was so insightful because he sees this too, that fat people who snore tend to be sleepy. Okay. So for a long time, we just made a note of it. And in the mid 20th century, there started to become an increasing signal that people with this phenotype, heavy, snoring, and sleepy, right? People with that phenotype tended to die young. They were more apt to get right heart failure, pulmonary hypertension, congestive heart failure, arrhythmias. So this phenotype that started to be dubbed Pickwickian syndrome, heavy, snoring, sleepy, that phenotype began to garner medical attention. And people started to cast about as to why these people are sleepy. Isn't it interesting? Because this was right around the same time that we were starting to investigate sleep as scientists. It wasn't until the 20s that we even had a tool called the electroencephalogram, right? The EEG wasn't introduced till the 20s. So they started using this, and wasn't until the 50s that we started to realize there were things called sleep stages and stuff like that. So, it's all getting very interesting in the sleep neurology. So right around the mid 50s, somebody puts out a paper, a guy named Burwell, and he says, I know why Pickwickian people are sleepy, because he admitted somebody to the hospital who was Pickwickian and did some blood tests and found out that he was CO2 narcosis. He had his carbon dioxide level in his bloodstream was too high. And so there became this instant narrative of, Pickwickian people are sleepy because they're CO2 narcosed, because all this weight, they can't have respiratory excursion anymore, so they can't ventilate, right? Their CO2 levels are too high, that's why they're sleepy. Okay, now we understand. And it wasn't until 1966 that somebody decided to actually study the sleep of a Pickwickian patient. This was a guy named Henri Gastaut, and he was a Frenchman who was an expert in epileptology. So he studied seizures, and he was an expert in the EEG. So he decided to take a real live, true to form Pickwickian patient and put this guy in the sleep lab and figure out if there was something identifiably wrong with his sleep, right? This was in 1966. And what did he find? Well, he found that this person had terrible sleep apnea. And it was not just obstructive events, but central events too. And so this concept of the breathing was interrupted became a thing in 1966. And we didn't know about that until then. So now we have this new idea. Oh man, they're not breathing. What do we do? Well, I don't know. Tell them to lose weight. That's what we do. You're all shameless. You should lose weight. It's your own fault. And oh, by the way, if it's really bad, we'll cut a hole in your neck. And so, that was literally what we had to offer back then. And so people weren't lining up for treatment, right? But, if you poke a hole in the neck and reestablish breathing, you can make them not be sleepy anymore and you can restore life. So some people chose to do that. Mm-hmm. So meanwhile, quietly in Australia, a man named Colin Sullivan is researching obstructed airways in dogs. So dogs with smashed faces and stuff. And he's figuring out how to push air into them to make it so that the airway obstruction doesn't happen. And he develops this thing using, I believe it was a paint compressor. I've heard another story that it was a vacuum cleaner, but the motor from an air compressor and little things that you screwed in to regulate the amount of pressure coming out. And he put it on a non-invasive ventilatory mask over the nose. He called it nasal continuous positive airway pressure. And he published a case series in 1981 documenting how a series of people with real Pickwickian syndrome, real big bad sleep apnea, and he completely normalized their breathing and sleep staging in one night with this miraculous thing that he created called CPAP. Boom. An industry is born overnight. This was 1981. And so in the 1980s and 1990s, we start to see CPAP sort of springing up, and sleep diagnostic centers are starting to spring up in different places because it becomes very clear that if you can make this diagnosis, you can sort of, some people will cover treatment. And so there's this proliferation of the business end of this, which results in a very tight crackdown from federal insurance about how this can be diagnosed and when it's appropriate to provide treatment, because this is a very, very big financial problem now. Okay. So Medicare comes up with this idea that, we have this study, several studies at this point now that show that there is actually a trend towards increasing mortality from sleep apnea. And I'm just going to throw the Wisconsin Sleep Cohort 18-year follow-up study from 2008 out there as an example of this. This is where we got the idea that mortality tracks with AHI, the apnea-hypopnea index. And there is no bones about it. The Wisconsin Sleep Cohort 18-year follow-up trial from 2008 shows us definitively that if your AHI is above 30, your obstructive AHI is above 30 with the 4% desaturation criterion, there is a very clear trend that this is going to end you sooner than you should, right? 18-year survival rate for the untreated sleep apnea with AHI of 30 was 57% as compared to the referent population, AHI less than 5, where it was like 97% survival. Wow. So that is real. That you can't look away from that. As a result of these kinds of data, Medicare says, we'll cover sleep apnea if the AHI is greater than 5, But that concept, that cultural concept, has sort of become the normative idea. And the AHI has been turned into something almost like a barrier now, where your AHI is only 4. You don't have sleep apnea. Go someplace else. You don't belong in my clinic. And that person, if we keep up with the actual diagnostic criteria for sleep apnea, which is established in this book, the International Classification of Sleep Disorders, the American Academy of Sleep Medicine has grown. They say, if you have respiratory effort related arousals, these are just a flow limitation that causes a brief arousal from sleep. Doesn't even have to cause a desaturation, right? If you have 5 respiratory effort related arousals per hour, 5 RERAs per hour, and you've got symptoms, according to this document, you have obstructive sleep apnea, G47.33, right? But that simple fact has not translated to a cultural awareness of this. Right,
and aren't there a lot of sleep labs that aren't even testing for RERAs?
Yeah, and because the accreditation standards are that they're optional. You don't have to, and so it's a complex discussion as to, why are people being turned away when they need help? Right. This is part of it, is that the language has taken over. The AHI and the jargon has come to life, and now that's what we're dealing with, rather than this beautiful complex physiology. And there's lots of moving parts with why a person has sleep apnea. That's the complexity that we need to be talking about now. Yeah. Not, do you have an AHI greater than 5 or not? Yeah. That's not the problem that I'm trying to solve anymore.
And neither with me in children of an AHI of 1 or greater. It's the same battle I fight, because if you look at a lot of my dental colleagues, especially in orthodontia, and especially in the academic world or the organized dentistry world of orthodontics, they focus on an AHI and they literally judge treatments. They look at two things. They look at monotherapies and they look at the effect of a monotherapy on AHI. And anytime I see that come from some study that they run, and then the conclusion, and all the people who don't want to believe that what we're seeing and talking about today is real, or we can have any real definitive preventative impact on when these patients are younger and are children, and help them grow better and breathe better and establish nasal breathing, which we'll come back to in a moment to talk about the importance of all that. They use these to clutch their pearls and say, see, if you expand or if you get tonsils and adenoids removed, there's no difference in AHI. And I look at those, I'm just going, that is so, they're missing, they've just completely missed the point. As you just went into great detail on and spent time elaborating on, it is so much more nuanced than that. And it is so complex that to distill it down to just this number, and correct me if I'm wrong, Dr. Guilleminault knew it, right? Later in his career. I mean, he openly spoke about what you were just saying, right?
Yeah. It's interesting. It was designed as a metric of severity, something that we could say, it's like blood pressure or a temperature, like it's bad because the number is this. Blood glucose, right? It becomes and so it has an attractive quality to it, and in some cases, like when you have a pure obstructive sleep apnea person, where the AHI is really driven by obstructive events. And I'm saying this with emphasis because I'll tell you, here in the mountains, the central apnea component of this is not to be ignored, and it's often the major player, right? It's often the star of the screen. But if you have a pure obstructive problem, and we're talking about an event like an obstructive apnea, there is clearly a linear progression towards badness. The more of them you have, the worse it is. You know what I mean? There's no doubt about that. Sure. And let's just explore this with a little demonstration. If you are having an obstructive apnea, what you are literally doing is, as you are inhaling against a blocked airway. Right? I do that for dramatic flair, but there's another name for that in English, right? That the word is choking. Choking, that's to say. Right? That's what breathing against a closed or a semi-closed airway is. It's choking. Okay. So when we explain it like that, we realize that the physiologic response to choking is going to be different than the physiologic response to a pause in breathing that follows a sigh, which is what central apnea physiology is. It's several deep breaths. Then there is a pause. And typically that pause is during the sort of sleep phase, and it is when the oxygen is dropping. And there will come a point where it creates enough of an alarm where there is a gasping recovery breathing series. Okay. So there is a sympathetic arousal that happens with that, but it is different than the sympathetic arousal that happens from choking. Okay. And as a result of all of this, when we talk about the difference between obstructive sleep apnea and central sleep apnea, and we say, why do we want to treat these? For obstructive sleep apnea, risk is a big problem. If I don't treat this, you're going to have a stroke, right? Obstructive sleep apnea risk. It'll kill you younger because you'll have a heart attack. Risk, choking. Central sleep apnea, when it's pure, does not carry that signal. Okay. So when you read textbooks and why do we treat central sleep apnea? It's because it disrupts sleep. It's because it makes you feel crummy. But we don't have the signal that this, like Pickwickian syndrome, carries this signal for, you're going to die younger and get heart failure. That doesn't happen because of central sleep apnea. People who have heart failure can experience central sleep apnea because, circulation time, the time it takes for blood to circulate around the system, that gets longer when you have heart failure. And so longer circulation time contributes. It's one of the moving parts of central apnea physiology. So people who have heart failure can have central sleep apnea, but it doesn't mean that we have to treat it to prevent them from dying. Okay. We have no signal that fixing central sleep apnea prevents early death. Isn't that weird to think about it that way? But I'm calling attention to it because of that vanilla chocolate swirl. And when we're telling somebody, oh, you need treatment for this, we better be sure of what we're offering them, right? I'm going to treat this problem because of X. Well, this is where the empowered sleep apnea approach comes in real handy, because there are 5 reasons we can consider putting someone on a treatment strategy for this case of sleep apnea, right? Those 5 are risk, like I was just talking about. That's the hardest one to talk about because you have to unpack the AHI to talk about that. But the first reason is risk. Second reason is snoring. I call that out by itself because it's a unique problem for sleep apnea and it has its own unique set of circumstances. Some people don't know they snore, for example, but it's still a problem because snoring is trauma, right? It's rattling. Snoring causes neurovascular damage to the structures rattling around, right? So it's a cause of progression of the disease. Snoring is a social irritant, and so it causes intimacy problems and lack of co-sleeping, So there's lots of stuff wrapped up in snoring. That's why it's listed as its own reason. The third reason to treat is the sleep experience. So sleep. If the sleep experience is broken, they'll tell you about it. I'm waking up all the time. I have to get up every 2 hours to pee. I don't feel like I dream. I don't have any deep sleep. So the sleep experience being broken is a reason to treat. Fourth reason to treat is the wake experience. So if the wake experience is dysfunctional for any reason, it doesn't have to be daytime sleepiness, folks. It might just be, I feel scatterbrained or I'm an asshole to people, I can't control my mood because I'm frontally released, So the wake experience, whatever problems you're having there, it could be due to the sleep apnea. It could represent a reason to treat. And then the fifth reason to treat is comorbidities. There's lots of them. In fact, the Academy took them out of the ICSD-3 as kind of co-founders for the diagnosis because there's so many problems that go along with sleep apnea. Things like migraine headaches, hypertension, temporomandibular joint dysfunction, bruxism, irritable bowel syndrome, reflux, asthma. Like the list goes on and on. I used to play a game with my fellows, name an organ system, and let's talk about how sleep apnea jacks it up.
Yep.
So I think of these as vulnerable comorbid conditions. And this is something that the provider just sits down with the patient and says, what are you being treated for? Let's talk about it. Depression? Yeah, that could be worse if sleep apnea is not treated. Anxiety? Sure. Headaches? Sure. You go down the list and you realize that all of these problems might potentially get better if we get a control over the sleep apnea, right? So once we sort of have the understanding of which reasons are relevant for you, then the patient says, oh, I do have some reasons to treat. I get it. What do you got, doc? Now it's time to start talking about, what do we potentially have to offer this patient? And that's where we can have the conversation about the many moving parts of sleep apnea. It's not just CPAP deficiency, folks. Let's talk about things like oral posture, right? Just opening your mouth while you're breathing enhances the likelihood you're going to get not just obstructive sleep apnea because, hey, it releases the tongue and fall back, but you're going to be more likely to overbreathe during your recovery breathing, and then you're going to enhance your tendency towards central apnea physiology. So just closing your mouth at night can have a functional difference in how you breathe, right? Isn't that astonishing? Like, there was an article I found online by a really, really revved up science journalist, and I forget his name now, but it was an article that was front page for the Kaiser Health News. So like this is big distribution. The title of it, I'm going to paraphrase, but it was something like, Diagnosis of severe sleep apnea, panics reporter until simple low-cost solution was found. And I'll tell you, this man was not feeling charitable towards the medical establishment. He was hot because in his lens, he had been given this label, severe sleep apnea, and had been walked through several mandatory tests for him that cost him, and he was given a very expensive machine. All of it came to a total of in the thousands of dollars. And then that far in, he found through his own research what I just told you, that posture can have an effect on sleep apnea. It's a simple concept, but he taped his mouth closed and slept on his side, and his AHI normalized essentially because those moving parts happened to be pretty important for him. Okay. The point here is not so much that, oh, wow, they screwed up. The point here is he felt ripped off because he didn't know that.
Mm-hmm.
You know what I mean? Because the complexity was not revealed at the beginning.
Yeah, do you think it's a diagnostic problem in terms of, I mean, there's obviously a communication problem as well as providers, but do you think that's because they didn't take the time in diagnostics that they needed to take?
No, it's not that at all. It's that it's simply not on the radar screen to talk about it in this way. Because this is a diagnosis that has a treatment that's approved by Medicare and Medicaid and insurance companies.
Okay.
Functionally and practically speaking, the efficiency machine has turned this into a quest to get you on CPAP as quickly as possible.
Got it.
And I understand it. It's like door to needle time in the hospital when you have an MI.
Yep.
It's door to CPAP time. I get it. It's important. However, the patient does not experience any sense of agency when the complexity is revealed after the fact. The patient will feel ripped off. So my progression here in my clinical practice, and now that I'm chief medical officer of an ecosystem called Rebis, what I'm teaching my advanced practice providers is that there is a script that you go through that helps people sort of understand, helps people along the way to make their own decisions, and it makes everything better. And that script involves a discussion of the many moving parts of sleep apnea and the understanding that you can poke at this problem from many angles. And CPAP is one way, and it's often an acceptable way and an effective way of normalizing the breathing, but it's not the only way, Yeah. And if people are introduced to the idea that, hey, mouth posture is part of this, if sometimes we just keep your mouth closed, it can make a big difference. All of a sudden, the downstream repercussions of that is that they're thinking, oh, wow, I wonder, maybe I shouldn't be on this big oro nasal mask that I breathe with my mouth open, because now I know that nasal breathing is better for me. Maybe I should try the nasal mask. Maybe we can turn that pressure down so it's not blowing air out my mouth anymore. You see? So thinking about the goal is not just to establish CPAP compliance. The goal is actually to help the patient rediscover effortless nasodiaphragmatic breathing day and night, right? It's a completely different set of procedures that we're going to go through to obtain that goal, as opposed to just, let's get this patient on their CPAP.
I'm so glad you said that, because that is one of the things I'm fighting for within the orthodontic and dental community. And I come up against a lot of resistance, no pun intended, to the conversation.
Upper airway resistance.
Exactly. We'll have to start a new thing, resistance to upper airway resistance. So the problem that I find is there's this sentiment out there, and there was an article written to one of our most prominent journals about this recently, and it created a bit of a buzz and discussion, talking about the fact that mouth breathing really isn't that big a deal. Yeah, it can be, can cause some problems, maybe, kind of, sort of. There's no real way to measure it. There's no way to quantify it. So kind of all the studies that say it's bad are really pretty useless. And at the end of the day, humans can breathe through their mouths just fine. Obviously, I think most of my audience would know, though we can certainly refresh it, the benefits of nasal breathing. I'd love to hear from your perspective. More than that, though, why is it so important to try to get kids nasal breathing properly? And if we neglect to do that, do you see that there can be a higher incidence of these kids developing breathing problems and then sleep-related breathing problems later in life? Do you have questions about a clinical case? Or maybe a challenging practice management issue? Or maybe you're a new doc who's starting a practice and doesn't know where to turn for advice. Doc's private one-on-one coaching platform is here to help you succeed in all these areas and more. Just go to theorthocoach.com and select coaching from the menu to enroll. And now back to today's podcast.
Yes. Well, yes. And thank you for bringing this up. Because the mantra that I'm laying down for my new clinical ecosystem is that we are sort of a nasocentric clinic. Breathing through the nose is important. And I'll just list a few reasons why. Number one, it affects the autonomic nervous system. We have pretty good data, and I'll send you papers, and so we can have a bibliography for this episode.
Sure, put in the show notes, yeah.
But we have data that supports the notion that breathing through the nose tips the parasympathetic to sympathetic balance towards the parasympathetic, right? Conversely, breathing through the mouth tips that balance towards the sympathetic, okay? So just understanding that very small, singular, elegant fact parasympathetic nasal breathing, sympathetic mouth breathing, right? All of a sudden, it changes everything I do in my sleep medicine practice, right? You have insomnia? I want you breathing through your nose, right? It so happens that everything we treat here in the sleep medicine clinic, almost everything we treat is associated with a hyperarousal type of condition, tipped towards the sympathetic. Chronic insomnia? Absolutely. Restless leg syndrome? Absolutely. Obstructive sleep apnea? Absolutely. Okay. So if we're thinking about how we want to help these people move towards health, teaching them that simple, elegant fact. I want to get you breathing through your nose effortlessly day and night is a big goal, right? Because we breathe all the time. Constant signal towards sympathetic is not what we want, okay? That's just one. Number two, when we breathe through our nose, the paranasal sinuses are elaborating a substance called nitric oxide. Nitric oxide is a vasoactive and antimicrobial molecule. So let's decode that. Vasoactive means, we know this from our experience with Viagra. NO is a vasodilator. Okay. What this functionally amounts to in the lungs is when you are breathing through your nose, you have more bioavailability of oxygen because there is more bioavailability of the circulatory system to absorb that oxygen into your system because of nitric oxide. Okay. So the person who's been sort of the shining light and teacher of all of this worldwide is Patrick McEwen. He started his career at Buteco breathing, and now he's just sort of a celebrity figure who teaches people how to breathe. And he can give you all the data on this in his talks, but it allows for better oxygen extraction. So think better exercise performance. You're breathing through your nose versus breathing through your mouth. Think better recovery time. Think less physiologic stress, less work as you're doing your stuff, okay? So that's the metabolism side of nose breathing. Third thing, during development, while we are growing from babies into adults, the position of our tongue and airflow through the nose is what is sculpting the shape of our face. So if we're breathing with our mouth open, the tongue is not in contact with the roof of the mouth, right? The tongue is down here. And so the upper jaw does not develop like this. The upper jaw will develop like this. And when it's shaped like an A-frame building, well, the floor of the nose is the roof of the mouth. So that means that the nose is correspondingly collapsed just like an umbrella. If we're not having airflow in and out of our nose, it is airflow in and out of our nose with equilibration of pressures in the paranasal sinuses. So literally, if you grow up only breathing through your mouth, if you plug your nose from birth, you've got a fighting chance that you will never develop paranasal sinuses and your midface will not develop right. Your AP dimension of your face is going to be blunted this way. You'll have a flat face. When this happens, the oral vault is simply smaller and the jaw ends up recessed and set back. And this is a perfect description of a setup for adult sleep disordered breathing. On top of all of that, instead of breathing through the nose, which introduces nitric oxide, which is antimicrobial, right? We're breathing through our mouth. And so we're introducing all of these foreign toxic microbes to our lymphatic system instead, right? So we get hypertrophy of the tonsils and adenoids. Mouth breathing is not bad for you. I would respectfully beg to differ. It's very bad.
Yeah, and thank you for explaining that, because it is something that, and it's clear that the individuals who make these claims, this is not meant to be derogatory. It's just really a statement of fact. They don't understand the pathophysiology in that sense. They are literally just looking at it from the sense of oxygenation. Well, you can survive with your mouth open. You can survive breathing through your nose. And they're literally dumbing it down, inappropriately so, to its most basic form, which is survival. Yes, point conceded, right? You can open your mouth and survive, and you can breathe through your nose and survive. They stop there, and that's where it begins and ends. And it's amazing to me that when we have so much data and so much literature out there to substantiate the benefits of nasal breathing from the perspective of both medical and craniofacial growth and development, that we could have so many people, especially in the orthodontic community, who literally put blinders on and just still focus on the teeth in children. And they look at it and say, No. High vaulted palate, genetics. Recessed lower jaw, genetics. Mid-face deficiency, genetics. And when you try to explain the fact that maybe we should look in a little more detail at how this child is breathing, and maybe we should start to try to get them breathing better through referral to our medical colleagues and or development and growth modification, functional adaptation of the craniofacial complex, they look at you and literally it's this look of, why would we do that? We straighten teeth. To me, that is my bit, talk about your mission with Rebis and with empowering the patients and then empowered sleep apnea. My mission is to try to educate and empower my colleagues to understand that there is so much more we can be doing than just looking at teeth.
It's a scary truth. And in my podcast and in my blog, I tell the story of Ignaz Semmelweis.
Yeah, please go. For those who don't know, would you mind? Because I love that story.
It's a cautionary tale because Ignaz Semmelweis was an obstetrician who lived in the mid 19th century in Vienna. He was a Hungarian dude who was working at the maternity hospital in Vienna, and we're talking 1830s. Okay, it's a long time ago, but this was a time of enormous growth of medical science. It was a time of anatomical discovery. So the big shots, the real big guys in medicine, were all in Germany, in Europe, and they were really perfecting the art of autopsy science and understanding disease. And so basic idea, if you died, the physician's role was to go in and take the body apart and describe what we saw. So at the time, puerperal fever was a huge problem in the maternity ward. And puerperal fever is an ascending infection, a bacterial infection of the uterus that gets bloodborne and causes death a lot. And in the day, back in the 1830s, this was killing 25 to 50% of young mothers in the maternity ward. So it was horrendous. And the way the death happened was grisly. Like, you would get horrible pain, terrible fevers, you'd get spots all over you, blotchy, and then you'd circulatory collapse, and in a matter of days, you'd be dead. And we're talking, these would be otherwise young, healthy mothers. Now, if you were rich, you got cared for at home. So the maternity ward was for prostitutes and poor people. Okay. But the word on the street was they had an alternating admission system. On Monday, Wednesday, and Friday, you went to Clinic A. The rest of the week, you went to Clinic B. Clinic A was run by the doctors and med students. Clinic B was run by the midwives. The mortality rate was known on the street, and Clinic A was through the roof. So people would, hey, put me in Clinic B, put me in Clinic B. No, it's Monday, you're going to Clinic A, screw you. And the way they did their rounds was every morning, first thing in the morning, they would do the rounds in the death room. They would do the autopsies. This was before germ theory. That wouldn't come until the 1890s with listening.
That's true.
Okay. So, but they would go to the death room. They would do these autopsies barehanded, right? So that means they'd get in the pus and all this stuff, and they take the organs out and look at them and put them in pockets. And then literally, with their hands smelling with the putrescence of death, they would go next door to the maternity ward, and they would serially pelvic exam every woman on the ward with these hands that smelled like death. Now, one day, now enter Ignaz Semmelweis, strange, quirky Hungarian guy, speaks accented German. He's kind of a weirdo, but people like him because he's got a fun sense of humor, okay? He is doing an autopsy one day, and one of his beloved autopsy science mentors gets a medical student, nicks his arm with a scalpel. It was during an autopsy of a woman with puerperal fever. 3 days later, I'm making this up, but days later, this guy succumbs to a sepsis syndrome that began in his arm and looked exactly like puerperal fever. And Semmelweis saw all of it, and he couldn't unsee it. And he got this idea fixed in his head that there was something on the scalpel, something in the death particles that was transmitting disease. Okay, so he was prescient. He discovered germ theory practically. And so what he did was he said, okay, and his role at the hospital was he was kind of like the chief resident, so he was kind of a peon, but he ran stuff. So he said, from now on, you guys got to dip your hands in this bowl of chlorinated lime before you go in the maternity ward, and just do it until they don't smell like death anymore. Okay, that's my new rule. You guys have to do it. People are like, what are you? Okay, whatever. You're weird. People are running around him. He's chasing them down. But he did this for a whole season, and the mortality rate of puerperal fever dropped to almost zero. And he was busy doing the jiggy dance. Like he's like, I did it. You guys have to do it my way. He published a single report that said what he did. And everybody who was the starched upperlings there was like, you're crazy. Trends like this come and go. We see this. It has nothing to do with the death particles. You're nuts. This is where Semmelweis took a turn for the worse. He started to berate people, and he started to castigate people, and he started to write letters. And he wrote letters to every major medical school in Europe, and he called their people murderers and said God would punish you. So Semmelweis didn't last long. Okay. And eventually he got ran out of town on a rail. He lost his friends. Even the students who were kind of rallying around him stopped calling him. And in the mid-1860s, he was admitted to an insane asylum after being brutally beaten by the guards, we later discovered. He died 14 days after admission. Get this, ironically, of a hand infection that had turned septic, right? I mean, it's just, you can't make this up. You can imagine him pounding on the glass, begging to let him wash his hands, and they're like, death particles, whatever. Yeah. When they, what do you call it when you get somebody's remains out of the grave?
Exhume.
When they exhumed his remains, they found thoracic trauma that they said could only have come from a boot stomp. They literally stomped him to death. Right? This is what society did to the man who discovered washing hands saves lives, right? So I tell this tale for a reason. Actually, there's one more bit to this tale that I have to reveal. There was an obstetrician named, I think his name was Michaelis. We can fact check this later, but he was in Austria. And he was an early adopter of Semmelweis's idea. So he read the report, and he had lost his niece to puerperal fever the season before. Okay, so someone he really cared about died, and he instituted this hand washing practice, and he saw his mortality rate go away. And this gentleman couldn't live with his guilt. This is the point. And he took his own life within 4 months of his discovery that this was effective therapy. So that part of the story actually gave me pause, because this is a dangerous truth now, right? This is a truth that takes lives when it is realized. Yeah. And I was brought back to this bit of the tale when I did my episode on Bill Hang. Listeners in your circle may know who he is. He's an expansive orthodontist who discovered his truth kind of mid-career, and it made him frankly feel like he felt hopeless. He felt like he had caused harm. And so as we're rolling out this new truth, this idea that, the shape of our face is developmental, and we need to be helping to reach full development, not crippling the development by pulling things back. That notion that making the oral vault smaller causes harm, that is a very dangerous truth. It's true. I believe it's true. But for the orthodontists who have spent their career pulling teeth back, using things like cervical headgear, things that might actually affect the maxillary jaw, like these are things that physically change the shape of the oral airway. I mean, there's no question about it. And in my worldview, we see adult sleep disordered breathing because of these interventions. However, finding a signal for it in the literature is hard to do because no one's doing the right research, because it's too dangerous of a truth. We don't want to know yet. Because we're like that guy in Austria. That guy who took his own life after he realized that Semmelweis was right. So anyway, somehow I feel this incredible responsibility that when we're talking about these ideas, we have to understand how scary it is for our colleagues who have spent a career practicing in a way that we're now discovering might have repercussions.
I'm so glad you said that. And it's such a great story. You tell it so well. And really, the premise of that story is exactly what you then finished with. And that is, history tends to repeat itself in weird ways because it's human nature, is my belief. There are certain innate qualities in all of us, and self-protectionism and not being able to accept our failures and accept a different reality is just who we are. We protect ourselves. And I've said that often on the show. You've heard me publicly say, to grant some of my colleagues grace, some of the ones that come at me the hardest and disagree with me the most, I literally say, I feel sorry for them. And I don't mean that in a condescending manner. I'm being truthful. I look at, and when I gave the lecture the other day to your group, I showed just a couple cases where I was guilty of missing it very early in my career. I wasn't trained on this. I didn't know this. Just looking back on those couple of cases, that handful that I treated in that manner, where I was treating the teeth, constricting the arch form, ignoring the high vaulted palate, ignoring the transverse deficiency, ignoring the vertical growth, and really just trying, noticing them in some capacity, but ignoring that I could really do much about them, that I just had to try to look at them and take them as pieces of a puzzle to decide how they would impact my ability to give that patient straight teeth and a quote unquote good bite or ideal bite or ideal occlusion. Yeah. And looking back, it's very humbling to look at that. And I actually think, my gosh, these kids that I did this to, these couple kids, where are they today? They're adults now. This was 20 years ago. Where are they? Now, I very quickly in my career, within the first couple of years, stopped taking that treatment approach, started with more of an early treatment, expansive concept. I had no idea about airway at that point. I was just going, I'm just not treating the problem here. I mean, the problem is not big teeth in these kids. If you built your entire career on not washing your hands, yep. And in this case, on treating the teeth and treating the symptom, treating the crowding, how do you look back on your entire body of work and say, and in the case with Semmelweis, at least there, I mean, there was a very severe outcome that they were debating, and that was death. It gets even harder in the orthodontic arena because the patient still looks pretty good when you're done treating them. It's not like the patient has any morbidity or mortality at that point. The patient could have a very nice smile. They might not have OSA at that point, right? Maybe they just have some signs of sleep disordered breathing. They're on that clinical spectrum, but you didn't take the time to look. How do you convince that person that in 20 years, meaning the orthodontist or dentist, that in 20 years, they're going to show up to your clinic? Potentially, there's a greater likelihood of that person showing up to your clinic and have that person stay sane. And I mean that's not really a hypothetical question. Seriously, I mean, I think that's something we have to talk about.
Well, this is not going to be solved with a conversation or a shouting match. Mm-hmm. This is going to be solved with data. Mm-hmm. And so this is a call for all of our colleagues who are doing sort of expansive orthodontia, that we need to have sort of a real world research publication agenda. Mm-hmm. And I see this as being kind of a case control dance off. 100 consecutive patients going to an expansive orthodontia practice compared to 100 consecutive patients with similar malocclusive characteristics who go through a standard practice orthodontic scenario. And then we have some sort of objective follow-up for those 100 people in both arms 10 years later. Mm-hmm. That's the study that's going to make people change their minds, because it's going to be irrefutable. Mm-hmm. Right now, all we have is anecdotes. Mm-hmm. And just like the folks in Semmelweis' day, we see these things come and go, these trends. Mm-hmm. So you can't say that this was causal, mm-hmm. right? Mm-hmm. I think you had someone tell you that when you said, look what happened. Mm-hmm. I did these things and we see the adenoids and the tonsils regress and we see the sinusitis clear up. Mm-hmm. Explain this to me. And he says, could be just that was what the universe was going to deal this person. Mm-hmm. That just happened, and you were on the bus at the same time as that rider. Mm-hmm. Not causal, right? That's what Semmelweis' friends said. Yep. When the mortality rate dropped in his hospital. They said it's not related. So this is a job not for arguments, but for science, I think.
Yeah. I completely agree. And one thing I've spoken about too, and it comes to me in stories like Semmelweis, even stories like Lister, Pasteur, before this concept of evidence-based was it's in its infancy still, the concept of evidence basis, and starting Cochrane in the 70s and Sackett and kind of into the 80s and 90s. And
where's my book? I carry this thing around like a Bible. This was required reading for us in residency.
Let's see, bring it down a little bit. Oh, there you go. Yep. Okay.
Epidemiologist. This is the book from which the term evidence-based medicine came from, although it wasn't used in this book.
Was Gordon Guyette in that one too? Is that him too? Was it Sackett and
Sackett, Haynes, Guyette, and Tugwell?
Yep. So
some of my favorite Canadians besides James T. Kirk.
Yeah, and they said there's three parts to it, right? The clinical experience, and then the science, the data, the evidence, so to speak, which they're very clear, does not have to be a randomized control trial. That's kind of an ideal, but they're clear in that it doesn't have to be. And then the patient perception and values, and where those intersect is the sweet spot in that Venn diagram. That is evidence basis and evidence-based practice. And there's an interesting article that was written a year after Sackett's death. I think he died in 2015, that talked about how evidence-based medicine is being hijacked. And it's being all focused on just that one circle that is a randomized controlled trial. And we don't have to go into the details on how it's being hijacked or by whom. The fact is that when you look back at some of the visionaries before they had this anvil sort of on their shoulders of proving it through evidence basis, which has been, say, this randomized controlled trial or whatever the case might be, they were able to speak to things and see things in ways. I think it was kind of unencumbered, right? They were able to just be free and think and propose ideas. They weren't always accepted, but I almost feel like our ability and our capacity to free think and propose ideas, we have to be careful. We can't just trust every anecdote or every case as a one-off. I just look back at how many things. What was one of them? The use of insulin in diabetic ketoacidosis, or one of the uses of penicillin in bacterial endocarditis. And these concepts that happened before we had any concept of a randomized controlled trial, but we still realized there was validity. So I feel like as a scientific community, we have to come together. And in all of this, and I want to tie this back into Rebis and what you're doing and how we started all of this, is the patient values. Where in the treating to the average, Peter Attia talks about this in Outlive, right? That medicine 2.0. Where is treating to the average? Where is that one study that we can pull and then say this applies to everybody? Where is that in the best benefit of the patients who don't fall into that range? Right. Yeah. And I feel like we just need to open this discussion more. So with that, I'd love to hear your thoughts on that. And then if you want to take that into how you are doing exactly that with what you're building with Rebis, I'd love that.
Yeah, I agree with you. The randomized controlled trial has been celebrated for good reasons, because it's kind of the pinnacle of the scientific methods proving of causality, However, you can't do randomized controlled trials for everything. It's not ethical, for example. Let's take sleep apnea. Did you know that we do not yet have a randomized controlled trial that demonstrates a mortality benefit from the use of CPAP?
I did not.
It's true. It's because that trial would be unethical to conduct. Here's why. To do a randomized controlled trial, it needs to be okay to put someone on no treatment and observe them for a while, right? It's not okay to randomize someone to no care for a long enough period of time to discover whether it'll kill them or not anymore, right? So the way they worked their way around this for a big trial that came out in the New England Journal, this was the trial that was supposed to demonstrate a mortality benefit of CPAP. And this is a trial that is getting CPAP into a whole hunk of trouble, and I'll talk about that in a minute. But they took people with sleep apnea who were considered to be high risk. So think somebody who's already had a coronary event, so secondary prevention now. Somebody who has the disease, now that puts them in a different risk category. Because once you've had a heart attack, you're in a different risk category from somebody who hasn't, right? So a lot of people who are at high baseline risk who have a diagnosis of sleep apnea, okay? That's our group. We want to see if using CPAP keeps people from dying or keeps something bad from happening to them, right? So I've just told you it's not ethical to do that, because we know CPAP can help people. The way they got around this is they said, well, what do we know about CPAP? We know that if you're sleepy, it can make your sleepiness better. This is proven, right? They did this with a trial. So we know this. If you're sleepy, it makes you less sleepy to use a CPAP. So what we're going to do is, if you're sleepy, we're going to put you over here and you can't play in this trial. You're not in this trial anymore because you're going to need to use CPAP. So the sleepy people go over there. It's only the people with an Epworth score of less than 10 that get to play in this trial. So now we've changed the population a little bit. It's not everybody. It's just the people who weren't sleepy who have sleep apnea. Maybe those people are different. Maybe they have like the gene from Krypton that makes them more resilient. We don't know. They're just not sleepy, okay? But they're a different population. Now what are we going to do to them? We're going to give them CPAP. How are we going to do that? We're going to put it on AutoPAP 5 to 20. And we're going to let the machine show us what it does. And somewhere along the line, we may choose to put them on the 90th percentile pressure. But the starting point was AutoPAP 5 to 20. Did they use their CPAP machines? Sure they did. On an average of 3 hours a night, plus or minus 2 hours. That was the average, okay? And I'm here to tell you that when people are using their device not at all, it's because the device is not comfortable and it doesn't feel like it's doing them any good. That's my clinical experience, okay? And my clinical experience is also that AutoPAP 5 to 20 is too wide of a range, and it usually overpressurizes people, and overpressurization leads to noncompliance. Okay, so that's my comments about what they did in this population. So all of that being said, they randomized some people to use CPAP and some people didn't. The people who used CPAP had no mortality benefit, no benefit at all. In fact, we're now getting post hoc analysis that those who had pressures higher than 7 centimeters of water actually had worse outcomes and higher inflammatory markers in the bloodstream. Okay. In other words, CPAP, we're now getting a signal, can cause harm. Did you hear that? CPAP might cause harm if it's dialed up too high. Holy smokes. Talk about something complex, right? So all of this is to say that even the thing that everybody struts around saying is the gold darn standard is not proven to be great yet. Okay, we don't have that data. So what do we make of all this? Should you be afraid of your CPAP machine? No, you shouldn't. But we should come back to the idea that we're doing this for a reason. There are 5 reasons to treat this, like sleep, weight, comorbidities. And the notion that we're doing something good about risk, I think we need to have a long conversation about this. Is your treatment improving your risk? Well, how do we know? Well, we can check some sort of follow-up data. We can check data from the machine. We can maybe do a follow-up. Now we have the ability to do a home sleep apnea test for somebody on CPAP. That's weird because we used to have to do a test with measurements of the airflow and breathing, right? You can't use that with a CPAP machine, but now we have a different way of assaying the physiology. We have something called the sleep image platform, which measures the physiology of sleep disordered breathing, not the breathing. So it measures heart rate variability and peripheral arterial tonography, and those patterns can give us clues about that map to numbers like the AHI, okay? The bottom line is the idea of evidence-based for anything is a very complex subject. And it's not just about a randomized controlled trial. There are other ways to understand disease that have nothing to do with that. And as scientists, we're obligated to look into all of those.
Yeah.
You wanted me to talk about Rebis. You want me to do that?
Yeah. Well, thank you for that amazing explanation too. I appreciate you going into detail on that. Seriously, that is great to hear that from your perspective on that as well. So yeah, please talk about, as we kind of wind down, talk about this new project. It is super exciting. It is taking a lot of the complexities that we have talked about in this episode to this point and assimilating those into a really innovative solution, taking away the very siloed nature of our healthcare system. So go talk about it. I want you to share that.
So this is really all about complexity management, Mike. So, the traditional method is the physician is the caretaker and the custodian of the complexity, packages this complexity up into neat little diagnostic categories like obstructive sleep apnea. You have G47.33, go, prosper. And then downstream from that, we'll have a fleet of advanced practice providers who are carrying out orders according to an algorithm. So following, how is obstructive sleep apnea managed? Let's look in the book. Well, CPAP. That doesn't work. Well, what's next? Mandibular advancement device. So it's very label-based and very treatment-oriented. The flip side of that is to democratize the complexity. Is to take this idea of the many moving parts of obstructive and central sleep apnea, they're mixed together, and lay that in front of the patient and the advanced practice provider. Give the advanced practice provider the language to deconstruct that complexity with the patient in real time. That's what the Empowered Sleep Apnea Project is about. It's not just empowering the patient, it's empowering the actual provider to unpack the complexity in a responsible way that the patient can understand. So the ecosystem that I'm designing is about democratizing the complexity. Literally. So the PA will be able to have that 5 reasons to treat discussion, break it down, and the patient will be able to choose the right treatment for them at the right time, understanding that there's many moving parts. So the ecosystem will also include integrated into it an airway-focused dentist who can talk about not just mandibular advancement device therapy, which is still an important part of our landscape, but also these newer and field-engineered expansive orthodontic options, both for kids and for adults. And integrated in our system is also going to be behavioral sleep medicine. This is a big problem out there in the wild blue, where behavioral sleep medicine is basically understanding the physiology of sleep and helping people to understand it themselves and helping people choose the right behaviors and self-talk to best navigate their problems, right? All of that is lumped up into a term called cognitive behavioral therapy for insomnia. And that has been mystified, unfortunately. It's been kind of, put off on its own in its own little place because it's harder. You have to get special training, the saying goes, and you have to see a psychologist, and you can't bill this through insurance. So many sleep centers just simply don't support it. That's going to be integrated and also democratized, meaning that all of our providers will eventually be able to offer this service to their patients in real time. And then lastly, the integrative medicine component of this. One of the complexity deconstruction tools I teach about in the Empowered Sleep Apnea Project is the 5-finger approach to non-specific sleep-wake complaints. Listeners can find this. This is a paper I wrote back in 2010 for the Journal of Clinical Sleep Medicine. And it's basically a way of saying, what could this be? I feel crappy. What could it be? Right? And the 5 fingers are circadian misalignment, pharmacologic factors. You want to query those, medical factors, psychosocial and psychiatric factors, and then finally primary sleep diagnoses like sleep apnea. So for medical factors, the idea is that, I feel lousy and I sleep poorly. Go, right? There could be medical problems that are part of this issue. Like, for example, I'll just give this as a brief personal example, vitamin D deficiency. Vitamin D deficiency. When I was working at LSU, I started to see a signal that people were just coming into my clinic and they couldn't sleep because they were achy. They were tired and their muscles hurt and stuff. I found that amongst my African-American patients, if you said, yes, pain is a part of what is bothering me about my sleep-wake experience, daily pain, there is a greater than 90% chance that you were vitamin D deficient. And clinically, I found a signal that when I treated it, people often felt better. One person actually normalized her Epworth score just by fixing her vitamin D level, right? Went from an Epworth score in the teens to the single digits. And that was the only thing that changed. It's weird. I published that one in the Journal of Clinical Sleep Medicine too as a case report. But the idea here is, boy, a medical problem can contribute to this patient's sleep-wake experience. How odd. Now we have an integrative medicine director at Rebis, and we're sort of taking the integrative medicine strategy to heart, that we can follow that rabbit hole if we want to. And we're going to be teaching our providers sort of the Rebis way of understanding things like functional medicine, things like what is an anti-inflammatory diet? And what do we tell our patients about lifestyle modifications that might have a salubrious effect on the sleep-wake experience? So this is all worked into the ecosystem now under the director of integrative medicine, a woman named Lori Medina. So all of this is sort of my dream come true about really working within an ecosystem that the complexity, we can all handle it and we can all talk about it, and the patient doesn't need to be left behind.
I love it. I love it. That is the wave of the future. I'm telling you, in all aspects of our healthcare. I hear from so many people all the time, and they say to me, just when I was speaking up at the PANI meeting a couple of weeks ago, I can't tell you how many people came up to me and asked me this question, or I get the email of it, and they say, how do I find a team? How do I find people? There's 1 or 2 ENTs in town, and they just don't think that going in and doing anything with these kids young is necessary, or the pediatric allergists just don't want to do a lot of testing on young kids.
It's like it's a sense of desperation. People they are desperate for someone to listen to them.
Yes, and it's so hard because I can't solve that, right? Like I'm like, I try to educate and get people out there and have people like such as yourself on my show and get this content as wide-reaching as I can. That being said, it's still a real problem. So the fact that you really are a visionary, seeing this problem and then doing something about it to try to bring these different disciplines or different components of one discipline, so to speak, under one roof and allow that patient experience to be completely different than anything else that's out there. I give you such credit for it. I can't imagine the complexity of what you have built if you distill it down into the real X's and O's. Someone who ran a practice, has run multiple businesses, I know the challenges therein. It's pretty impressive to think that you were able to put together something at this level of complexity.
Well, let's talk again in a few months. We're still, the Rebis project is still young, and it has been a transition.
I imagine.
So we are definitely running, but we're not full steam yet because we took basically a quite large and fragmented clinic where the providers had individually kind of become individually siloed. There was really no culture left because everybody was working at home and there was no common language. So with all of that, every individual provider was doing things slightly differently. And so it's difficult to provide cross coverage because you might get a different story here than there. So what this has been an exercise in is, how do you build a culture? How do you build a culture? And the answer is you have to get people together and they have to talk to each other, and we have to sort of have a language that we can share. So that's kind of what I've been doing. Most of my work has been about mojo coordination, getting people organized and getting people to sing from the same songbook. And it's easier said than done.
I can imagine, but I'm confident in you that you are going to be able to achieve it. And really, I just thank you so much for all you're doing, all you continue to do, and embracing the dental community. I really appreciate that because it helps us to see it from the medical side. And the fact that you've taken the time to see it from our side, that relationship, it's kind of that co-discovery, right, that we talk about with the patient and the provider. We need co-discovery amongst colleagues in different disciplines here, and to be able to start to think a little bit differently about things based on what some of our colleagues who have maybe a greater expertise in one area or another think. And thank you for that. And I'll put links to the Empowered Sleep Apnea book here. It's great. It's really unbelievable. It's like an encyclopedia of information.
Yeah, but don't be afraid of it. Just because it looks like a textbook, I'll tell your listeners, it's not a textbook.
No, reads like a storybook. Yeah.
It's an adventure.
It's an adventure. Yeah, it really does.
It's way more fun than a text.
Yeah, completely. It's just got so much information in it, but done and presented in such a really simplistic way. You take very complicated concepts and present them in a way that makes it simplistic. And your gift as an artist and your cartoonist background is pretty cool because you draw some pretty neat stuff in there. So how can people reach you, Dave? What can they do to reach out to you? I'll put the link to the Rebis website for sure, but if they have questions or want to speak with you in more detail.
Yeah, you can reach me through the website, www.empoweredsleepapnea.com. Click the contact button and it comes straight to me.
Okay. Great. And anything else you want to mention about that people can look into or resources? I'll put some links to those, or I'll be in touch with you to get me the links to those different articles so we can throw those in the show notes. But anything else you want to mention or have the audience aware?
No, sir. Just keep up the good work. I love what you're doing. Thanks. I love your sensible approach and your candid and transparent sort of approach to science. I really appreciate what you're doing. So thank you.
Oh, thanks so much. It means a lot to hear that. I greatly appreciate it. So Dr. Dave McCarty, it's been an absolute pleasure as always. Thanks so much.
Thank you, Mike.
All right.
Talk to you soon.
Take care. Bye. Thank you for tuning into this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses or to schedule a private one-on-one coaching session with me. Also, if you know of someone who would make a great guest for this show, or if you'd like to be a guest yourself, please email me at drmike@theorthocoach.com. And be sure to join the Doc community on Facebook for more great content. Thanks so much for listening, and always remember, you have been blessed with the ability to do amazing things.